Hello, everybody. It's lovely to see you. I have
Yeah.
seen many of you already today. For those of you I haven't, my name's Nicole Shaveldra. I'm Director of Patient Experience. I also wear another hat because I'm the SRO, Senior Responsible Owner of the work that the Trust is doing on the NHS England Undertakings, which is what I'm here to talk to you about today. So you may think, what is Nicole doing talking about this in this capacity? That's why. It's because I wear another hat as well. I am going to endeavour to find the slides that I have prepared for you, which is all about those undertakings and the Trust's single improvement plan. If somebody could just let me know if you can see that, okay?
Yep.
Smashing. I'll put it on reading view because I think it's a little easier to see. And then I'll talk you through this. So, bit of context, you'll know most of this, I think, that the trust was formed in 2021. It was the merger of two previous trusts, or the combining of the two. And you'll be aware of the scale of our organisation across 7 sites, 20,000 staff, and us providing care for more than 9 million patients a year. And we've been undergoing a period of organisation development since the point that the trust was formed, obviously in the middle of a pandemic. Since the point at which the trust was formed, we have been subject to a significant programme of regulatory inspection from the Care Quality Commission, as well as some other independent reviews, and you'll be aware of the number of inspections that we've had as a relatively new organisation coming out of a pandemic. So we've had insights and recommendations come from a number of sources, including yourselves, from our patients, from what our data intelligence is telling us, our partners in NHS England and in the ICB, which has driven the creation of a single plan for improvement. Some of this came out of our communications with NHS England following the CQC inspection last summer. There were some discussions between the ICB and NHS England about where the trust should be in terms of support from the central NHS England team. NHS England advised that a number of conditions or undertakings should be assigned to the trust, and that we would be expected to meet those conditions as were set out by NHS England. A single improvement plan was one of those conditions from NHS England, which is why we've done that. You'll be aware that over the period since the trust was formed, there's been a trust strategy and there's been a number of improvement programmes. What this plan seeks to do is to bring the key improvements together in a single document, a single plan and a single set of governance. So this little wheel describes the 9 domains that are fundamental to our improvement plan. So CQC, so responding to the CQC inspections and their recommendations. Quality improvement, so that's patient experience, safety, clinical outcomes and effectiveness, amongst others. Culture, which is featured heavily within the CQC reports that have been received. Surgery, which includes in particular a number of programmes of work, one of which is the Trust's response to a review done by the Royal College of Surgeons, but also changes to the surgical clinical operating model, and improving access to surgery. So looking at how, as a merged organisation, we use the totality of our theatre capacity most effectively to have a single patient treatment list, where patients are seen in the most appropriate theatre as quickly as possible, and that should reduce some of the waiting times for patients. Not as easy as it sounds, doing all of that, particularly moving provision across different sites, but that's a programme that's underway. Planned care, which also includes cancer, urgent and emergency care, equality, diversity and inclusion, a set of services called specialised services. These are services that are commissioned by specialised commissioning, part of NHS England, and that includes things like PET CT scans, mechanical thrombectomy. So these are specific contracts for specific specialist delivery of activity against a number of areas, many of which require quite specific equipment, hence why it's called specialised services, and also maternity. Each of these 9 domains has got an executive lead and an SRO, so somebody like me who's a trust director who's responsible for driving the delivery and coordinating the work around those areas. Some of those 9 domains are established work programmes, so things like planned care, urgent and emergency care, maternity, for example, are very established programmes of improvement work with their own governance. Others were new, CQC and quality improvement and culture, and that's where the quality and safety improvement programme QSIP came from. It creates a programme structure to accommodate those work streams in a coherent way. As a temporary arrangement, the Trust has established a QSIP committee. Name might change to reflect the fact it's the whole of the undertakings, and that's chaired by a non-executive director to oversee the delivery of the requirements within this plan. And reporting to there is a steering group, which is chaired by George. It's an executive steering group, and that provides the operational oversight of the work against these domains. We've now also got a monthly provider assurance meeting that is in place between the Trust and the ICB and NHS England. And there's a regional meeting of NHS England that is receiving the plan in its entirety next week. So I haven't shared the whole of the plan with you because it isn't approved yet, but it felt like a good time to be telling you about it because we're hopeful it will get across the line next week. Let's see, might get some feedback and some things we need to change. So yeah, let's keep our fingers crossed it gets over the line. So the plan, this is quite small, and it was just the visuals to give you an idea what the plan looks like. For each domain, we've got a plan on the page. They look like this. So I've just included a snapshot of the CQC one and the urgent and emergency care one. And those set out the ambitions, milestones, risks and performance indicators for each of those. You will get sent the whole plan, by the way, so you can read those in detail. We're going to develop a dashboard against each domain that will be reported to the committee. And there's also a public facing document that is in development, something that explains what is quite a complex plan in an easily digestible form. And that's being developed by the comms team. But obviously that won't be released until we've got a plan that is actually approved by the region and that we can talk about with some confidence as being something that we're fully signed up to. And the plan has a risk register. So I wanted to flag there are a number of quite high, well, very high scoring risks within that. Not least that the delivery of the plan incurs some significant financial investment at a time when finances are extremely tight and we're having to reduce the amount we spend as a trust rather than increase. So whilst the plan is there, meanwhile, there's loads of improvement work taking place, and I've included a couple of examples here. Again, I'll talk you through it so you can understand what they are. But in the quality improvement work stream, a lot has been done to develop something called fundamental standards of care audits. So these are audits on the wards using a digital system where the nursing teams and other clinical staff go and they do patient experience rounds. They check on things like the falls prevention work that's taken place, news, so sepsis scores, infection prevention and control, etc. And they're brought up on a dashboard, and these are now reported weekly. So there's a really high level of sort of ward to board oversight of compliance with these audits. We've developed this compliance and assurance framework, the CAF. I've done you a little excerpt of it here, the one that looks like a big multicoloured quilt. It's just a tiny excerpt of a huge document, and this lists all of the requirements in the new CQC framework. There are 5 domains in the CQC framework: caring, effective, responsive, and well-led. And this includes all of those domains, and by division, the extent to which we're compliant with those requirements. So it really shapes where we need to be driving our improvement efforts. So for some, it'll be that there's a difference between the divisions. Some divisions might, excuse me, might be quite strong on some things, so there's an opportunity for sharing learning. For others, it might require a more centralised effort to move things forward. It is a new framework, by the way, from the CQC, so there are things in there that everywhere in the country will require some work to move on. We've also developed a quality governance manual, which is a guide for clinical leaders that will be released quite soon, that describes like what good quality work should be every day. If you're running a clinical area or if you're a divisional director, what are the things you should be doing every day to ensure that care is quality and safe for your patients? So I just wanted to share a few examples so you don't think we're got our finger on the pause button whilst the plan is being developed. There is a huge amount of improvement work that is underway, a lot of which you've heard today. But hopefully that makes sense and gives you a little insight into what is happening with the single improvement plan, why we're doing it, and what it'll look like when you get the chance to view it in its entirety. Thank you. I welcome any questions or reflections. Doug.
Yeah, specialised services.
Yes.
Is the money for that ring fenced?
That's such an interesting question. Do I know the answer to that question? So it's a block contract. So you receive, let's say, I'll X million pounds for the delivery of X number of scans or particular interventions. In terms of the money being ring fenced, the money is received by the trust. I'm not sure it has been ring fenced. It becomes part of that clinical services operating budget. I think it's an important question because that might be something that needs to be considered if we're going to keep a tight grip
on this.
on
Do they
this.
suddenly say this was a specialised service, but everybody's doing it now, so we won't be paying you the extra for that?
Unlikely. Callie seems to know a lot about this, so do come in, Callie.
No, because specialized services are about specific procedures and also specialized services like neurosurgery and cardiac surgery and so on. And Nicole is right. They're not officially ring fenced, but it's a block contract. So, for example, they would give neurosurgery X million pounds and expect them to deliver on what they have to deliver. And invariably, what happens is it is never overpaid, if that makes sense. So the block contract might say, in specialized pediatric surgery, for example, it might say you got to deliver 500 this type of patients, but usually you end up delivering more than that.
Yeah.
And so in fact you are never overpaid, Doug. So it's very difficult to use that money for other purposes, but it is within the department. So it is within the gift of the departments to use the money, but they have to deliver on their contract. That's the bottom line.
Yes. It's distinct from most of our business, which is paid by activity. So you're paid by patient, by procedure, whereas the block contract defines a level of activity that you would expect the service to deliver, and the payment attached to it. So it's a different style of contract management.
And
I hope
for
that makes
us,
sense.
within UH Sussex, there'll be very specific areas which come under specialized contracting.
Yes.
Whereas, for example, in some places, like if it's the Marsden or the Royal Brompton, virtually all their contract will be under the specialist commissioning because they are specialist hospitals doing very specific work.
Yes. So things like mechanical thrombectomy is one that's currently there, and that supports stroke patients. It's a particular intervention and they require specific equipment that wouldn't be available on every hospital site. So that's a really helpful distinction, Callie, I think. It's the things that are specifically commissioned from specific sites rather than a kind of universal offer that you would expect on most hospital sites.
And Doug, you're right. If a particular type of intervention becomes so generalized that it's no longer specialist commissioning, then it'll be taken out of the specialist commissioners. So it is not up to us, but it's up to them. But it won't be halfway through the year. So once they have commissioned you for that financial year, you'll be fine. But the next year, if they determine that, and it doesn't happen suddenly, it doesn't happen like that. It happens over a period of time. And more, actually, some of these areas are getting more centralized and specialized rather than the other way around because of numbers, and we have had this conversation in other sort of circumstances within our groups, haven't we? Where we know that certain things are getting centralized, and sometimes it's actually difficult for patients to accept as well.
Thank you. Fran?
Yes, thank you for making something really complicated look quite straightforward. But the stuff you were showing us was quite high level, and I suppose the like an assurance model, you know, and showing that you're on it. How does that translate to sort of activity and being linked to being able to demonstrate that these things are happening on the ground? Where does that happen? How does that happen?
It happens in a number of ways. So each of those plans on a page includes the key performance indicators. They're the metrics by which we know whether those things are being delivered and whether they're being successful. So, for example, on the CQC one, the main metrics are the number and percentage of the should do and must do recommendations from the CQC that have been completed. For others, it will include things like our compliance with our 4-hour performance. Many of those things are included, in fact, most are included within the Trust's integrated performance report, which I believe you see through the Council of Governors. So you'll see the outcomes and whether those things are being delivered through there. As I said, there's differentiated governance for each of these domains. So, for example, maternity is subject to a significant programme of governance with the ICB, with the system, and reports that go through the Patient and Quality Committee and up to the board. For urgent and emergency care and planned care, the governance is also through the committee structure. Equally for equality, diversity and inclusion, much of this is already viewed within our business as usual governance, but there are some new elements within here, which is why this temporary arrangement of the committee has been established. So we will have to determine where do things like specialised services go, what's their business as usual governance, and whether things like the surgery programme of work, whether that becomes integrated as part of business as usual governance or whether it's kept as a sort of programme that is delivered on a fixed term basis. So that there isn't a straightforward answer to that, but there is a dashboard that will go against each of these 9 domains that confirms the extent to which they are compliant with the plan. So there'd be an escalation to the committee. If there's deviance from the plan, that would require an escalation and a specific report. So we've set out what should happen and when it should happen. If things don't happen when the plan says they should, that's when there'd be an escalation to the committee.
So the overall sort of intention would be to enable all of these things to end up as business as usual, as good practice, business as usual. But because of the CQC monitoring, etc., you have to maybe have some extra activity on some things or new activity. Plus, you need to actually be able to demonstrate very clearly to the CQC that this is business as usual now, or whatever. Is that the sort of
this specific work, so the single improvement plan is very much linked to the undertakings. So these were the asks of the organisation from NHS England and also from the ICB. So a different type of regulation to that provided by the CQC. So it is in response to our regulators and requirements from our regulators, but a different set of regulators. We were required to have this by NHS England within their contract to us.
Right. So there's a the undertaking to the NHS England, there's the CQC, and then there's business as usual, you know, what you'll be doing, etc. And it's trying to get some coherence around all of these things. So
it is. Want to be have it all in one place.
Yeah. Okay. Got it. Okay.
Any other questions before I disappear to chair my next meeting? I hope that's been helpful. It's been lovely to see you all. Thank you very much for your time. I'm disappearing not because I don't want to be here, just because I'm needed somewhere else as well.
Fine. Thank you.
All the best, everyone.
Bye.
Thank you, Nicole. Bye.